Strokes, boy, that's something, it's a disease that's very scary. People say, I'd rather die in my sleep or have a heart attack, but don't let me have a stroke. And the reality is this, out of 4 people who have a stroke, 1 person unfortunately will pass away within the first month or so. 3/4 will live with disability up to about 10 years. So stroke is the 3rd leading cause of death and the 1st leading cause of disability. So the team has put together a wonderful presentation about how to treat and, more importantly, how to prevent stroke. Take it away.
Yeah, thank you, Dr. Curnew, for the introduction. So this is just a little bit about what we'll be getting into today. So we'll first cover what is a stroke, some of the causes, then we'll go into different algorithms for calculating your risk. We'll talk about recognizing a stroke, and then we'll talk about treatment.
Yeah, so first off, we'll start off with what is a stroke. So really broadly, stroke can be defined as a sudden loss of brain function, and it can be further subclassified into an ischemic stroke, which comprises the majority of strokes, or a hemorrhagic stroke, which comprises a minority of strokes. So an ischemic stroke, really briefly, is caused by a blockage in a blood vessel of the brain, whereas a hemorrhagic stroke is caused by a rupture of one of the blood vessels in the brain, causing bleeding. Next slide, please. Moving on, ischemic stroke can be further subdivided into 2 types, thrombotic and embolic. A thrombotic stroke, the blood clot will be developing within the blood vessels of the brain, whereas with an embolic stroke, the blood clot will develop elsewhere in the body and travel through the bloodstream into the brain. So essentially what happens is the blood vessel blockage impairs blood flow, which causes a lack of oxygen and nutrients to be supplied to the brain tissue, which then begin to die within minutes. On to the next slide, please. With a hemorrhagic stroke, the blood vessels rupture and bleed, as mentioned previously, which thus had the similar effect as the ischemic stroke of having a lack of oxygen and nutrients supplied to the brain. There's also irritation and swelling of the brain as well. And hemorrhagic stroke can be subdivided into 2 main categories, intracerebral and subarachnoid. With intracerebral, it's bleeding from the blood vessels within the brain. Subarachnoid is bleeding in the subarachnoid space, which is this sort of membrane layer surrounding the brain.
What's kind of interesting, Nicholas, is that stroke has changed a little bit. When I first started my medical career, we saw more hemorrhagic stroke. And the reasons for that is that blood pressure, the higher your blood pressure, that can actually rupture vessels inside the brain. President Roosevelt died of hemorrhagic stroke or had complications of hemorrhagic stroke. And one of the interesting stories is that after his stroke, he lived with disability, got confused. And so that made Russia a bigger country because he got more confused and he didn't always negotiate properly for the Allies. And so it's interesting, we talked about the beginning, as time goes on, we're seeing more ischemic type strokes and less hemorrhagic strokes. And subarachnoid hemorrhage is usually often a disease of we have these aneurysms that rupture, and those have some genetic factors. So it's amazing how stroke has changed, and we have to change with that. So one message you're going to hear loud and clear is controlling blood pressure. We are doing better. We can still do better. So plea number 1, every Canadian should have their own blood pressure machine and measure it on a regular basis, as I hope you'll learn as time goes on. Take away, Nicholas.
Yeah, for sure. Definitely some changes over time. So moving into epidemiology, specific to Canada, as the government of Canada, the last time they updated with a full-on census was early on in the 2010s. But at the time, stroke was the 3rd leading cause of death in Canada. So it's super important that we try to address this amongst our population. Additionally, it's mainly a disease that affects people who are on the older age spectrum. 10% of adults age 65 plus have had a stroke. The occurrence of the disease is 293 per 100,000, and it does have a mortality of 28.1 per 1,000 people. I'm not sure if Dr. Curnew wants to add anything. There might be newer data that Dr. Curnew knows about.
Well, I think you summarized it. The way I always think of it is that you can see we're saying roughly the same thing, is that most people who have stroke unfortunately don't die from their stroke. They die, they get disability. So difference between, if you have a stroke, you're going to lose a lot of brain cells and you won't be able to function as well. And you often end up in a nursing home at some point in time. So again, people with stroke, it's the leading cause of disability in older people. And being in a nursing home and not being able to walk or to pee or to function or to think properly and have high incidence Alzheimer's disease for about 10 years is a terrible way of ending one's life. So stroke is very much a preventable disease in many circumstances. So I think you showed that quite nicely. When you hear that people fear a stroke, yeah, I fear a stroke. And basically what you can do is manage risk factors better. And the biggest risk factor for stroke is high blood pressure, that we're going to talk about. And so people say, my blood pressure is always good, it's always at the doctor's office, you should know. No. You as an individual person should know your blood pressure and do it regularly and find out if you're at risk. And we'll learn more about what. Go ahead. Who's next?
Yep, for sure. So moving into causes of stroke, we're going to go over some risk factors at first. So on to the next slide. Here are some very key risk factors. Dr. Curnew probably discusses them a lot already, but these ones are quite specific to stroke. So we have things like stress and hypertension, which would be high blood pressure, tobacco and alcohol, having diabetes, being overweight is another, having a poor or unhealthy diet or a lack of exercise. If you're living a sedentary lifestyle, you really put yourself at risk for stroke. Additionally, we'll get into a bit more of atrial fibrillation and atherosclerosis in more detail later on in the presentation. And rounding it out, Dr. Curnew already mentioned genetics and age as being a particular risk factor for stroke.
So I really like this slide over here, what you're talking about over here. So we mentioned high blood pressure. Another huge one is atrial fibrillation, irregular heartbeat we're talking about. You can lower your risk of having stroke with atrial fibrillation by close to 70% by being on blood thinners. And so all these things are factors in all this. So keep teaching us, keep teaching us. And by the way, I'm actually having a soup over here. I hope everybody's eating right now. This is a vegetarian-based soup. It's rich in kale and fruits and and vegetables. It's sort of like a DASH diet. So dietary approach to stopping hypertension. You can lower your blood pressure somewhat by what you eat. We saw alcohol. Alcohol brings up blood pressure. Soup, if you have a vegetable-based soup, lowers your blood pressure. So I'm lowering my risk of stroke tonight. I hope everybody else is well.
So if we go on to the next slide, we're going to be talking a little bit later in today's presentation on lifestyle interventions like diet and exercise, as Dr. Curnew was talking about, but a big player in the game of stroke is atrial fibrillation. We can't really think about stroke without thinking about atrial fibrillation, and that's because people with Afib are about 3 to 5 times at greater risk of developing a stroke, and unfortunately about 1 in 4, about a quarter of the people over the age of 40 who develop a stroke, it's caused by atrial fibrillation. So it's important to recognize atrial fibrillation early so that it can be appropriately managed to minimize your risk of having a stroke later on in your life. Atrial fibrillation, of course, increases your risk of stroke, and to describe atrial fibrillation a little bit further, it's important to look at the diagram you see on the left-hand side. Essentially, you see that our heart is made of 4 different chambers, where our atria contracts, which is the top 2 chambers, the little ones at the top, followed by our ventricles, which then pumps blood out to the rest of the body. Unfortunately, in atrial fibrillation, the beating of the little chambers at the top is dysfunctional, and this disrupts the entire contraction of the heart, where then your ventricles are not contracting synchronously with your atria, and it can lead to a lot of pooling of blood in your heart. And this can unfortunately lead to clotting, which eventually causes those clots to travel to areas such as your brain, or it can also lead to other clotting disorders such as peripheral vascular disease. And so that's why it's really important to manage atrial fibrillation as soon as you can to prevent the risk of this actually happening and having an adverse event. So if we go on to the next slide here, we do have two pictures, two diagrams, which shows what a normal heart looks like and what an atrial fibrillation heart looks like. And you can see at the top here, this is a normal consistent contraction with the heart where these top chambers contract followed by your ventricles and causes blood to pump out to the rest of the body. You want your heart to be pumping at about 60 beats per minute. Now with atrial fibrillation, this is irregular heart contractions where the top two chambers aren't contracting nicely, followed by your ventricles contracting afterwards. And again, this leads to a heartbeat that is irregular, blood pooling, and unfortunately increases your risk of having blood clots forming, which can travel to the brain or other parts of your body. And so it's important to recognize what some of the symptoms may be for individuals who have atrial fibrillation and also recognize some potential causes to ensure that you're managing it appropriately. And we'll talk about that on the next slide. So on the next slide, you're going to see that there are many different ways in which an individual may develop atrial fibrillation. Some of the major players can be high blood pressure, congestive heart failure, coronary artery disease, cardiomyopathy, having diabetes, valvular heart problems, significant or substantial alcohol intake, excessive weight, increase in age. It could be familial, hereditary, or sometimes on occasion it may be caused by overexercising. And while there are many causes of atrial fibrillation, it's also important to recognize some of the symptoms. Of course, the typical symptoms may be palpitations, but you also may be feeling more fatigue or weakness, lightheadedness, dizziness, things of that nature. So atrial fibrillation, as I've mentioned, puts you at greater risk of stroke, and so it's important to know the common causes as well as symptoms of atrial fibrillation. So many individuals with atrial fibrillation may have these symptoms, but on some occasions as well, they may not actually recognize atrial fibrillation because it can be asymptomatic. In this case, you're not going to be experiencing some of these typical symptoms while you may experience fatigue or weakness. But the good thing is both symptomatic or asymptomatic atrial fibrillation can be recognized with diagnostic testings like Holter monitors that you would often get at Dr. Curnew's office or an ECG. And that's why it's important to have regular follow-ups with your cardiologist to ensure that you're not developing atrial fibrillation over time.
I think it's interesting, Stu. Did you get a sense what percentage of us will develop atrial fibrillation in a lifetime? Did you come across anything there?
It's a number more than it's a large number. I'm not exactly sure what this.
Yeah, so somewhere between 25 to a third of us will develop atrial fibrillation in our lifetime. It's rare under the age of 55 years of age, unless you have some of these risk factors here. So it becomes more common as we age. It could be totally asymptomatic, or you can feel your heart pounding and you can be short of breath. So the way I think of it, having atrial fibrillation increases mortality 2 to 3 times. It increases risk of stroke up to 7 times in some series, and increases Alzheimer's disease because what happens is atrial fibrillation causes stroke. Stroke causes damage to the brain. Damage to the brain leads to Alzheimer's disease later on as time goes on. So that's why you mentioned is that is knowing your blood pressure is important, but knowing not if you have atrial fibrillation and looking for that. So you mentioned having an ECG done. Sometimes if you have palpitations, we'll do a Holter monitor. Now we have other devices such as the Apple Watch and the cardiac monitoring device are a few examples how we're starting to look for it. So we have to be careful that we don't get obsessive about it, but looking for atrial fibrillation is and thinking about it is really quite important. So one message is don't get older, but if you do get older, make sure your blood pressure is controlled, make sure your heart's in good shape, make sure you're and one of the things is we're going to talk about, any degree of alcohol increases your risk of atrial fibrillation. So one time alcohol was a health food. It's not a health food. It causes cancer, it increases chance of atrial fibrillation and increases your blood pressure. And that's one of the things is that with the situation right now is that losing weight will help prevent atrial fibrillation too as well. Atrial fibrillation could be permanent or could be intermittent. So it's a sneaky thing in there, and it usually leads to big strokes. So that's why we want to really think about this. Go ahead there. Tell us more, Stuart.
Yeah, no, that's a really great point from Dr. Curnew. It really sums up why we should really care about atrial fibrillation. The statistics that I came across was from Heart and Stroke Canada. It said as of 2020, it was Over 200,000 Canadians were currently affected with atrial fibrillation. As you mentioned, mortality is increased 2 to 3 times when individuals have atrial fibrillation that's untreated. 1 in 4 individuals who have a stroke over the age of 40, it's caused by atrial fibrillation, and unfortunately, people are 3 to 5 times more likely to experience a stroke when they develop atrial fibrillation. So we've talked a little bit about what causes atrial fibrillation, how to recognize it. Towards the end of today's presentation, we're going to give you some insights on what you can do to manage it through lifestyle interventions, medications, and conversations with your doctor. So we'll get into that in a little bit. But before we do that, I'm going to pass it along to one of my colleagues who's just going to be discussing atherosclerosis as well.
Yeah, so I know oftentimes we talk about age as a massive risk factor, and unfortunately, we can't really stop the aging process. But something in particular with atherosclerosis that we wanted to highlight is how early on it can develop. So in the 20th century, there were a few studies with people from the war, from Korea and Vietnam, who were under the age of 35. And essentially what scientists tried to do is assess the prevalence of atherosclerosis in these patients. So they went under autopsy examination, and what they found was that coronary atherosclerosis was present in 78% of the study group. Bottom line here being that it can really develop early on in life, and it's definitely something to watch out and monitor carefully.
That's really important to bring that. Thank you for sharing that. So we're saying is that the average age of these unfortunate soldiers that passed away was around 25. And 3/4 of them already had plaque formation or fatty streaks or some form of atherosclerosis in their 20s. So you can see how this is a lifelong process. And, you know, we talked about atrial fibrillation being a major cause of stroke, but atherosclerosis is still the #1 cause. And it's really important. It goes silently and until something bad happens to you. Yeah, it's scary numbers, but you know what? You can do something about it. Go ahead there, Nicholas.
Yeah, we're just gonna be moving on to calculating your risk of stroke, and I'll pass it off to one of my colleagues.
Hi, so I'll be talking about calculating your risk score. Next slide, please. So your absolute risk score is your risk of getting a heart attack or stroke in the next 5 or 10 years, depending on the calculating system that you're using. So because heart attacks and strokes share many similarities in that both involve formation of blood clots in your vessels, they share the same risks and can be calculated together. So as you can see on the slide, those are some of the risk factors that we've mentioned that they measure. So some of the more major factors that they measure include blood pressure, age, cholesterol, your sex, any pre-existing disease like diabetes or obesity, your lifestyle habits, smoking, drinking, exercise, and your family history. So other additional factors that they may measure are your kidney function, if you have atrial fibrillation, stress, and the current medication you're taking. So in general, any percentage under 10% is considered low risk, 10 to 15% is considered moderate risk, and anything over 15% is considered high risk. Next slide, please. So one of the more frequently used tests in primary preventions of strokes in asymptomatic patients is the Framingham Stroke Risk Score System. So on the screen, you can see a sample of what you may see in one of these tests. It's basically a computational program and algorithm that allows you to measure your absolute risk by combining age, sex, systolic blood pressure, your use of antihypertensives, pre-existing disease, again, diabetes and coronary heart disease. If you smoke, as we mentioned before, atrial fibrillation, and your left ventricular hypertrophy, which is the thickening of your heart walls. So for this calculating system, less than 10% is considered low risk, 10 to 19% is considered moderate, and anything over 20 is considered high risk. So these scoring systems get updated constantly with new information, and recently the FSR was updated to include geographic/racial differences and non-traditional risk markers. And one of these markers that I'll be talking about is the high sensitivity C-reactive proteins. Next slide, please. So Before I get into this, I'll just mention something else that's kind of related. So as you grow older, I'm talking about 75 years or more, your eligibility for statin therapy gradually decreases. And this is due to a multitude of reasons, including questions on efficacy after a certain age, drug-on-drug interactions, side effects, and your quality of life. And so C-reactive proteins are an important marker that plays a direct role in promoting vascular inflammation and vessel damage by affecting low-density lipoproteins ingestions. And this is proven in clinical cardiovascular disease events. Any levels over 4% is correlated with 4% risk of developing fatal cardiovascular disease. But thankfully, this can be treated using statins. So as you can see on the slide, statin can lower hsCRP levels by up to 60%. So this makes CRP an important marker for not only cardiovascular disease and strokes and evaluating your risk, but also an important marker for determining your eligibility to use statin as primary or secondary treatment. So this can be the last factor that makes you eligible for statin therapy. However, no system is perfect, and there are concerns with using hsCRP as a marker as well. So much like blood pressure, CRP can show extreme variations within individuals with a standard deviation, so giving you a plus or minus of basically 1.2 milligrams per liter. So you can see how this can be a problem with the current guidelines we have. So as you can see on the slide, so less than 1 milligram per liter is low risk, 1 to 3 is average, and more than 3 is high risk. So just by the standard deviation, this can put you at low risk or high risk. So because of the large variation, we currently are doing more testing on comparing the CRP levels alone with cardiovascular endpoints. But these are just some of the concerns with using this as a marker, but it is extremely useful.
So it's kind of interesting you mentioned inflammation. So inflammation is now quite in vogue. Inflammation is caused by basically viruses, bacteria, so like getting pneumonia. So I'm going to encourage everybody to look at a webinar we just did, we just posted a couple of days ago on why vaccines are important. And this has nothing to do with COVID, just basically COVID causes strokes, pneumococcal pneumonia causes strokes, influenza causes strokes. And the leading cause of high CRP or marker of inflammation for most of us is just being overweight. That big tummy is full of inflammation. So losing weight is a great way of lowering your CRP. Other diseases such as rheumatoid arthritis, psoriatic arthritis, different immune diseases cause inflammation as well. So you bring up a whole new pathway right now that I remind to think about. So thank you for sharing that. And we also mentioned that stroke calculator. We should make sure we give that available to people to calculate their individual stroke rates. Have we done that at all? Or if not, we'll do that, because I want you to be able to calculate your own risk of having a stroke. Framingham is basically started in the 1940s that looked at risk of heart disease, but also has a stroke calculator too as well. So you can actually calculate both of those different risks. So if we don't have it today, we'll certainly put something up so you can actually calculate it. Thank you.
Yeah, that's a great segue actually over to our next slide, where we do have a schema which you might be able to use to calculate your risk of stroke. This is the CHADS score, which you'll see it's recently undergone a revamp to the CHADS VASC score with more research. And this is a time in the webinar where I do encourage everyone just to take a moment to calculate your own individual score, because it's going to be relevant on the next slide when we discuss what the risk of having an adverse cardiovascular event, specifically a stroke, is based on their.
So I see one more update we should make. So if anybody can actually name me there's one little thing that I would change differently on this CHAD scoring system. Does anybody any idea at all? It turns out age. CHADs used to use 75. We now have CHAD 65. So that 1 point now gets changed to 65. Can you actually cross off that 75 and put 65 into there by any chance?
Yeah, on the bottom right, we have the updated one with the 65 to 74 range.
Yeah. So the Canadian system is actually called CHAD 65. They get a point for congestive heart, for hypertension, and we now use age over the age of 65 for a point in Canada. Then diabetes, you get 1 point. In a previous stroke or a mini stroke called the TIA, you get 2 points. And, anybody with any points on CHAD 65 should be on blood thinners. Then we have this other thing called CHAD-VASc that you can look at too as well. So most of us use the CHADs on the left, and we call it CHAD 65 at this stage as a risk of stroke. And that's for people who have atrial fibrillation, irregular heartbeat that you talked about, either continuous or intermittently. We use that circumstance. In fact, we're actually involved, thanks to Connor, called Brain AF, and we're actually looking at people under the age of 60 having risk of stroke as well. And we're finding that age is a predictor of stroke, but lower ages might change that, and we'll have more information as time goes on. Thanks a lot, Stuart. Share more.
Yeah, absolutely. So the reason why we wanted to show you two specifically is because the one on the right is one that's you might be able to assess with the support of your doctor. You might not have all the information to come up with your exact score, and that's why we also provided one on the left, just that you can use tentatively at home today. But just to break things down, specifically on the right-hand side, I want to give you how to break down this to calculate your own score. So first and foremost, starting with the first column, you have CHF, or individuals with left ventricular ejection fractions of equal to or less than 40. If you are an individual who knows that you have congestive heart failure, or in your recent echo you've been informed by Dr. Curnew or your other cardiologist that your ejection fraction from your left ventricle was less than 40, then that's where you would tally 1 point. Now, if you go down and you're someone who's currently on blood pressure lowering medications, or you're someone who's got significantly high blood pressure for some time, then that's where you would add another point to your score. Again, if you're an individual who's equal to or over the age of 75 years of age, that's when you would add 2 points. If you're in the age of 65 to 74, that's where you would add 1 point. Unfortunately, this is a non-negotiable parameter. It's not something that you can necessarily slow down, but it is something to keep in mind when you're calculating your score. Now, there's also diabetes. If you are someone who's taking diabetes medications, or if you're someone who has an HbA1c greater than 6 in your most recent blood work, then you would add 1 point to your score. If you're someone who's recently had a stroke or a thromboembolism or a blockage, that has led to a cardiovascular event, that's where you would add a 2 to your score. If you're someone who has vascular heart disease, you would add 1. And based on research, it's shown that individuals who with the sex as female also have a slightly greater risk as well, and that's where you would add an extra 1 score. Now, recognizing that some of these things you might not know completely, it's maybe a bit easier for you to come up with a calculation based on the left side. So if you have hypertension, if you have congestive heart failure, if you're over the age of 75, if you're diabetic, or if you have stroke, you'd be able to calculate your score. So I encourage everyone just to take a moment, if you haven't already, to calculate your score, because on the next slide, we're going to give you a breakdown of what your 1-year risk of developing stroke is at the moment without taking any anticoagulant medications from your cardiologist. So hopping over to the next slide, you'll see that there's a bit of a breakdown in terms of what the actual score is and what your risk is. So for example, an easy way to read this is if you actually didn't have any points on that chart, you actually had a perfect score of 0, then you would say that your risk as of right now without any anticoagulants is at a 1.9% in a year's time. Now, if you go up the ladder and you had a score of 1, your risk would be 2.8. And at this point, that's where a cardiologist might consider providing you with anticoagulant medications, as they may fear that the risk of stroke outrisks potential risk of bleeding with anticoagulant medications. And you can see that as you go higher and your score increases, then your risk at 1 year is much, much greater, all the way up to a maximum score of 6, which can put you at an adverse risk of developing stroke at about 18.2%. So, of course, it's important to recognize these symptoms or recognize the risk factors that you have, so that with the support of your cardiologist or your family doctor, or wherever your healthcare providers are, you can come up with an effective team with medications and lifestyle interventions to reduce your risk immediately. Dr. Curnew?
Yeah, no, I think you illustrate that quite well. So we think is that the risk of being on a blood thinner is roughly 2% per year of a significant bleeding complication. The most common complication is a gastrointestinal bleed, so GI bleed. So that's why we think when your risk is about 3% per year of having a stroke, and your risk of bleeding is about 2% or so, that we think it's a good trade-off. Is that I'd rather have a bleed inside my belly than have a stroke and end up in a nursing home. So these are some of these calculations. Now, your risk of bleeding could be different depending on circumstances. For instance, if you drink, yeah, you've had previous bleeding, you have ulcers, your hemoglobin's low. So make individual decisions. So just give you some baseline information, and then, but I think most of the time is that you need someone to discuss this with you, but you should actually know your risk of having a stroke, and thank you for sharing that.
Yeah, so in addition to knowing your risk, it's also important to recognize when you might be having a stroke and what to do in this matter. So right now I'd like to pass it over to my colleague who's going to be going over how to recognize a stroke and what to do in the event.
Just backtrack that one slide. That's 2 to 20% per year. It's not, so if you have a CHADS risk of 6, that's 20% risk of stroke per year. So it's a cumulative risk over time. So that's a pretty darn high risk. And you can say 3% risk isn't that high, but you're 65 years of age, and every year your risk is going to be 3% per year. And usually if you have a bleeding complication, it usually occurs in the first couple of years of starting blood thinners for many individuals. So important to realize that that's per year, that calculation. Thanks a lot. Good. Let's learn out what a stroke is.
Yeah, so I'll be going over how to recognize a stroke. So probably one of the most important factors in minimizing damage is the time that you take to react to, call an ambulance and get treatment right away. So to do that, you need to recognize a stroke. So next slide, please. So one of the more common symptoms that you will find is numbness to one side of the body. And with that can come confusion, trouble seeing, trouble walking, a severe headache, agitation, nausea, vomiting, sudden behavioral changes, hallucinations, seizures, just general weakness, and shortness of breath. However, that can be a lot to remember. So in any standard first aid training, you will hear the acronym FAST. So F stands for face. You will see one side of the face drooping. A stands for arm. So if you think you see one side of the face drooping, you can ask the person to raise both their arms at the same time, and you'll see that they can't raise one side. S stands for speech. So they'll most likely have slurred speech. And time stands for time to call an ambulance. You want to call 911 right away. And you might also want to note the time that the symptoms start so that when the paramedics arrive, they can see how long the stroke has been going on for. If they appear to have symptoms, but the stroke clears up after a few minutes, they might be having what's called a transient ischemic attack, so also called a TIA. So this is similar to a stroke, but the blockage is only brief. For people who have been diagnosed with TIAs, you can look for an identification bracelet. They might have a bracelet or an anklet or a necklace, so you can look for an identification there. For undiagnosed patients, TIAs often go ignored just because the symptoms do go away. But if this happens to you or anyone around you, please recognize the symptoms, call 911, and you can also record the time, the interval between when the stroke attacks occur.
That's really important. Time is brain. So this is not you call your family doctor, you call your next door neighbor, you call 911 and you need to go to a stroke center. The stroke center in Hamilton is the Hamilton General Hospital, because time is basically brain, and brain is your life. So if you can't talk, your speech is slurred and you're not drunk, or you have weakness on one side of your body, you need to call 911 and get to a stroke center very, very quickly. Go ahead.
So that was everything. Yep. Moving on to treatments.
Okay, so we're going to be discussing some treatments for stroke / the post-stroke period. So we'll go over medications. These include things like aspirin, cholesterol lowering medications, blood pressure medications, antiarrhythmic medications, anticoagulant medications, and then we'll briefly talk about surgical options and lifestyle interventions such as diet and exercise. So starting off with aspirin. Aspirin, or you might see it as ASA, which is a short form for the chemical name acetylsalicylic acid. Is a non-steroidal anti-inflammatory NSAID. I'm not sure if anyone else can see it, but there's stuff covering the slide.
Yeah, it's too bad that some people decide to ruin things. Aspirin is a very effective therapy if you're actually having a stroke. This is a medical emergency. Yeah, it's unfortunately it's a bad outcome measurement. And right now, what we do is that you go to a stroke center and you get evaluated because there's so many things that you can do under these circumstances. So, and in fact, right now we're actually using often two blood thinners. Aspirin and Plavix is sort of evolved right now. So why don't we go to the next slide over here? So aspirin is a crucial factor about this.
Yeah, so it stays on the other slides too. Okay. So aspirin is a
So Stuart, is that what can we should we just stop and restart, or how should we do this?
I was gonna say, Aditi, maybe you can just take the screen sharing down for a second, and then just try to put it back up, and then
Yeah,
sure.
so we're gonna do this over here. So stroke is a very frightening disease, and if you think you might be having a stroke, we want you to get medical attention very quickly. So aspirin has been around for a long time. Go ahead, Aditi, tell us a little bit more.
Yeah, so aspirin actually falls into the category of non-steroidal anti-inflammatory drugs. It's actually the first drug that was discovered that belongs to this category. So if you heard of NSAIDs before, that's probably because you've likely taken them. Things like Advil or naproxen also fall into this category. So they're known to relieve pain, reduce fever, and lower inflammation. Aspirin happens to be a little bit unique in the sense that it has a role in secondary prevention for cardiovascular events, which we'll talk about in the upcoming slides. So it can be used in people who are at high risk of blood vessel disease, evidence of poor blood flow to the brain, high cholesterol, hypertension, diabetes, smoking, previous history of a myocardial infarction, angioplasty or coronary bypass, or transient ischemic attack, which is a mini stroke, or an ischemic stroke. However, it's important to note that when it comes to stroke, aspirin does not necessarily always need to be used. There is a distinction between ischemic and hemorrhagic stroke. And Dr. Curnew, do you have anything you would like to add on that topic?
Yeah, absolutely. Before you start aspirin, you have to make sure it's an ischemic stroke. It's not basically a bleed inside your head, because if you're bleeding inside your head, we give you aspirin, you will bleed more. So that's why we don't recommend you take any therapy for your stroke until you're evaluated. And the way we do that is that, as you learned, is that 80% of strokes are ischemic and 20% are hemorrhagic. So you need to have a CAT scan of your head before you embark on therapy. So that's kind of an important determination. Absolutely. And if you're taking medications that can make bleeding worse, such as anti-inflammatory medications or alcohol, your blood pressure is too high, we have to pause and decide what the best course of action should be. And it's interesting right now is that aspirin for secondary prevention. Let's hear a little bit more.
Yes, so there is a lot of evidence to support the usage of aspirin in secondary prevention. And what secondary prevention means is that you've already had an event happen, whether that's a myocardial infarction or a stroke, and you're basically taking medication and undergoing different forms of therapy to prevent that event from happening again. So the Anti-Thrombotic Trialist Collaboration published an article in 2009 where they looked at 10 trials using aspirin for long-term secondary prevention in patients with a previous transient ischemic attack or ischemic stroke. And it showed a reduced risk of any recurrent stroke over 3 years of 17% compared to the control group. And then another systematic review published in 2014 looked at oral antiplatelet therapy for acute ischemic stroke and found that aspirin reduces the odds of an early recurrent stroke in the 2 to 4 weeks by 12% and reduces the risk of death or dependency at the end of the follow-up period by 5%. So there is some evidence to support the usage of aspirin for secondary prevention. Dr. Curnew, is there anything you would like to add?
Yeah, so I think aspirin has been around for a long time. And so if you have an ischemic stroke, aspirin, and often we use a second blood thinner called Plavix for a period of months or so afterwards. So yeah, it's just one component of your therapy. We no longer recommend aspirin before your first stroke because aspirin has significant bleeding complications, increases the risk of bleeding complications by about 50% or so. But if you have blocked arteries, you had a stroke or a heart attack or blocked arteries in your legs, we'll recommend aspirin and Plavix. We also sometimes use other blood thinners as well. If you have atrial fibrillation, we'll use anticoagulant therapy, which we'll talk about in a few minutes. Go ahead, tell us more.
Yeah, so that's a great segue into discussion on aspirin as primary prevention. So there are some guidelines, or there was some thought initially that taking aspirin kind of prophylactically could prevent the primary incidence of vascular events. However, the research is quite mixed on this topic, and usually will point out that aspirin has significant complications associated with it. So a 2009 review found that a reduction in vascular events with aspirin for primary prevention was most likely due to myocardial infarction reduction and was actually not significant for stroke. So from the perspective of stroke, this review found that it wasn't really doing much. And then the ARRIVE trial consisted of over 12,000 US and European primary care patients between the age of 55 to 60 with moderate cardiovascular risk. They were randomized to 100 milligrams of aspirin a day or placebo a day. And they were followed for 5 years. So there was no reduction in the incidence of major cardiovascular events in aspirin. And the actual cardiovascular event rate for both cohorts within the study was actually lower than expected. So the primary investigators figured that this was likely due to other factors, such as lifestyle changes, other medications they were taking, or perhaps they overestimated the risk of this cohort. So overall, this trial found that aspirin as a mode for primary prevention didn't really end up doing anything. And when we take a look at the ASCEND trial, this was a trial with over 15,000 patients with diabetes who were randomized to either 100 milligrams of aspirin a day or placebo daily. And aspirin reduced the risk of the first vascular event, but there were serious bleeding events requiring hospitalization in the aspirin group. So the researchers could essentially not identify whether the benefit of perhaps reducing the risk of a first vascular event actually outweighed the significant bleeding that occurred in some of the trial participants. So if we take a look at the image on the right, so this is looking at participants with the event, the percentage, and it's looking at the first serious vascular event. So you can see in the aspirin group, the participants who had a serious vascular event that was their first event is lower than compared to the placebo. However, if we take a look at the incidence of vascular events alongside the bleeding, we can see, especially looking here where the non-fatal major bleeding is represented by this yellow color, it's higher in the aspirin than the placebo groups across all of these three branches right here. And we can see that there isn't too significant of a difference when it comes to the incidence of the first vascular event. So essentially the study concluded that while taking aspirin for primary prevention might reduce the risk of a first cardiovascular event, it came at the consequence of pretty significant bleeding complications. And as a result, they determined that the benefits did not outweigh the harms. And finally, looking at the Osprey trial. So this trial had over 19,000 patients enrolled. They were all 70 years or older, and they did not have heart disease, dementia, or disability at the time of enrollment. So 9,525 participants of the overall 19,000 participants received 100 milligrams of aspirin daily. The rest received the placebo. And what they noticed was that there was higher all-cause mortality observed in the healthy older adults who received the aspirin compared to the placebo. And it was actually primarily attributed to cancer-related deaths. So if we take a look at this slide on the side, we can see that the cumulative incidence of deaths related to cancer was higher on the aspirin than placebo. When it comes to cardiovascular disease, including ischemic stroke, it is a bit lower in the aspirin than the placebo, but not much of a significant difference. And then if we look at death related to major hemorrhage, including hemorrhagic stroke, we can see that the two lines kind of overlap each other. And finally, looking at death related to other causes, the cumulative incidence was actually higher in the aspirin group than the placebo group. So yet again, they concluded that aspirin doesn't really work for primary prevention. It in fact was had more of a negative impact on the trial participants than the placebo did. So moving on to more medications, so starting off with reducing cholesterol. So we talked about atherosclerosis earlier on in the presentation. And what contributes to atherosclerosis is high levels of circulating LDL that over time will create plaque. So according to Harvard Medical School, the benefits of statin therapy include anti-inflammatory and antioxidant properties. It improves vascular function, stabilizes cholesterol-laden arterial plaques, inhibits platelets, reduces blood viscosity, and reduces the risk of stroke. And that's more of a side benefit that we see as a result of all of the wonderful things that statin therapy is able to do. So in terms of statins and stroke, so there was a trial in 2006 called the Sparkle Trial, and it involved 4,731 patients who had a stroke or transient ischemic attack within the past 1 to 6 months before the study. And what was important is these participants also had an LDL cholesterol level of between 2.6 to 4.9. There was no known coronary heart disease at the time, and they were randomized to either placebo or 80 milligrams of atorvastatin, which is Lipitor. So the 5-year absolute reduction in the risk of major adverse cardiac events was 3.5% in the statin group. So again, if we take a look at some of the images from the study, we can see that the percentage of fatal versus non-fatal stroke was lower in the atorvastatin or Lipitor group than the placebo group. We can see in terms of fatal stroke, there's not too much of a significant difference there, but the atorvastatin is still lower than the placebo. And if we're looking at non-fatal stroke, again, the atorvastatin is lower than the placebo. And finally, looking at stroke or transient ischemic attack, again, we can see that the group that was randomized to the statin therapy had a lower percentage of incidence compared to the placebo. So overall, the study concluded that taking statin therapy was associated with a reduction in the risk of stroke and major adverse cardiovascular events overall. There are a few other trials that kind of support this data. So a trial in 2013 found that pre-treatment with a statin, so if the individual was taking either 40 milligrams of Crestor or 80 milligrams of Lipitor before they had their stroke, the stroke often tended to be lower in severity. And then a study in 2020 found that in patients who had a cardioembolic stroke, those who were given statin therapy during their hospitalization at a year follow-up, there was only 9.3% of major vascular events in the statin users compared to 20.5% in the non-statin users. So again, speaking to the impact that using statin therapy can have in both preventing stroke severity, but also post-stroke preventing recurrence of stroke and other cardiovascular events. Dr. Curnew, would you like to add anything?
Yeah, it's kind of interesting how we evolved. When we first started, we just had aspirin therapy, so we used aspirin for everything. And we now know that if you've never had a stroke or any blocked artery consequences, that aspirin has a weak, maybe 10% reduction in vascular outcome, but it has a sizable increased risk of bleeding by 40 to 50%. Now, statins came along, and statins actually have an impact on the atherosclerotic process, and it has a bigger impact on blocked arteries to the heart, less to the head. So you see benefit. What we also learned is that we sometimes combine more than one antiplatelet agent. So if you're having blocked arteries, for instance, in the legs, for instance, we use something called Xarelto and aspirin to a blood thinner at a low dose and aspirin therapy. So we become smarter at treating stroke long term. And so interesting. People say, "Well, I taken my aspirin, I'll be okay." Well, if you're relying on aspirin to prevent stroke, you're not really doing a really good proper job. So there's so much more you can do. So thanks for sharing that. Tell us more.
Yeah, so next up is antihypertensives. We also talked about how high blood pressure is a risk for stroke, and hypertension is one of the most prevalent risk factors for stroke. It's very common in the population. So treating hypertension is really important for both primary and secondary prevention. So hypertension is called the silent killer for a reason. It might not necessarily be symptomatic, but it increases your risk for a variety of different conditions, including stroke. And then post-stroke, it's important to reduce your risk as much as possible, which also involves managing your blood pressure. So in terms of guidelines, the American guidelines suggest a reduction of blood pressure to 130 over 80 millimeters of mercury as the main target. The European guidelines recommend a systolic blood pressure less than 140 millimeters of mercury, but ideally say if you can get it to 130, that would be the ideal target. So a 2021 systematic review, so a high quality of evidence that's looking at numerous studies, found that subsequent stroke occurred in 7.9% of patients on antihypertensive medication, but it was 9.7 in patients who were just taking the placebo or not taking any form of hypertensive medication, antihypertensive medication. So again, managing blood pressure is key to kind of mitigating your risk for stroke. And there are a variety of antihypertensive medications, some medications that can help lower your blood pressure. So the image on the right is a bit complicated, but essentially there are numerous pathways in the body that help regulate blood pressure. And we have a variety of different medications that will act on various aspects of these pathways to help regulate your blood pressure. So an easy way to remember the antihypertensive medications is A, B, C, D. So A stands for ACE inhibitors or angiotensin receptor blockers. So these are two different kinds of medications that act on this system called the RAA system in your body. And it inhibits blood pressure increase because the RAA system is responsible for activating a series of processes to help increase your blood pressure. So a common example of an ACE inhibitor might be perindopril, and then for an ARB, it could be candesartan. So B is for beta blockers. So these block the effects of epinephrine on the beta adrenergic receptors. And an example of that is bisoprolol. So they are primarily used to reduce heart rate, but they can also reduce blood pressure, especially in younger patients. Then there's calcium channel blockers, which slow the movement of calcium into the heart cells. And this overall can result in reduction in blood pressure. And finally, there's diuretics. These work on your kidneys to regulate fluid content. Fluid content, plasma content, blood content, they're all kind of related. And having changes in those can have an impact on your blood pressure. So they work on your kidneys essentially to help control your blood pressure. Dr. Curnew, is there anything you would like to add?
No, I think is that, how to combine medications is a job for people like myself to help you with. And in fact, most people require some combination therapy. Are you going to mention the Chinese data about the lower blood pressure today or not today?
I don't have a slide on it, but I can briefly mention it.
Sure. Why don't you mention that, Charles? Because if you go back one slide, you can see the target, 130, 140. It's actually lower now. Tell us a little bit about the Chinese trial. What do you remember about that one?
Yes, so they did do a trial in China. There was, I think, two. The one I remember is where they used a salt replacement that contained potassium instead of sodium. And they found that increasing potassium, reducing sodium helped with the lowering of overall blood pressure. And I believe there was another one we've discussed as well. Dr. Curnew, if you would like to talk about that.
Yeah, so there's two ways of lowering blood pressure. One is lifestyle changes. And one of the things is by replacing salt with potassium. I'm replacing salt with potassium. I'm having, if you just look at last week's presentation, Didi and others put together one about, vitamins and minerals, and basically foods that are rich in fruits and vegetables are rich in natural antioxidants. They lower CRP, but they also lower blood pressure. So the Chinese salt analog one actually lowered your blood pressure by about 2 to 3 millimeters of mercury by replacing salt with potassium. So you can get, so I'm getting rid of salt and using fruits and vegetables, lots of vegetables in there to lower my blood pressure. But also medications. There was a second trial that took patients who had stroke and were given a blood pressure target 110 to 120 systolic versus 130 to 140, and showed an additional protection of stroke and heart disease. So again, cholesterol is more important for heart disease, blood pressure is more important for stroke. So ideal blood pressure turns out to be 110 systolic, but you have to make sure you're not getting dizzy, you're not passing out and falling. So if you're a frail person prone to falls and dizzy spells, we'll have a different blood pressure target. But if you're a healthy individual eating good vegetable soup, doing the Wentworth stairs, then you should ideally have a lower blood pressure and up to 110 or so. I'm not saying we should use drugs to get to that level, but getting lower is always better. For every 10 millimeters reduction of blood pressure, you show a reduction of about heart attacks by 20%, by stroke by about 30%, similar to congestive heart failure. So being even more aggressive in blood pressure management in some people may be important, something to think about. Yeah, thanks for sharing that. So it's a combination. So first step is that you can't manage what you don't measure. You should measure your blood pressure at home, and you should change your diet appropriately to manage your blood pressure and use the right medications at the right time. And most of us will require a combination of good lifestyle changes and more than one medication. Go ahead.
Yeah, so we're going to move on to atrial fibrillation and stroke. And before I pass it off to Stuart to discuss more about atrial fibrillation, I'm just going to briefly tie it back to what the relationship between the two is. So we've talked about how atrial fibrillation is an arrhythmia, a major risk factor for stroke. So rhythm control can help reduce the burden of symptomatic atrial fibrillation, the number of episodes, the duration of episodes. Anticoagulation is more of a prophylactic thing. So 2007 trial showed that using an anticoagulant such as warfarin reduced the risk of stroke by about 64%. So atrial fibrillation is often managed with antiarrhythmic medications and anticoagulant medications. And the image on the right is just to reiterate the point of how atrial fibrillation could be related to stroke. Essentially, the stagnation of blood can cause a clot, it can travel to your brain, and that can result in a stroke. And I will pass it off.
So it's kind of interesting if you just backtrack. Oh, never mind. Keep going. Keep going.
Yeah, so as Dr. Curnew and Adib were mentioning, of course, there's a number of different medications. We've mentioned a few of these actually already, but I'll just briefly go through them as well. Rhythm medications, also known as antiarrhythmics, can often work to reduce the heart rate and also help to reorganize a disorganized beating of the heart, which can, of course, then prevent the risk of atrial fibrillation. And so it's important to recognize that we, of course, need to be cautious with any medications. Of course, some can be proarrhythmic, meaning it can lead to arrhythmia. So careful conversations with your family doctor, your specialists, your healthcare providers can certainly point you in the right direction, of course, into which medications would be best for you, given all the tests conducted and other things related to your heart. Now, as Aditi was mentioning, calcium channel blockers are often one of the first choices when it comes to antiarrhythmics. These are long-acting, long-term rate controllers. They make the heart a lot more controlled so that your atria is contracting synchronously with your ventricles. There are a few different options that you see listed here. The first one is the drug of choice, lowers blood pressure, and a second one as well that you'll see listed here reduces some other palpitations. Aditi also mentioned that beta blockers such as bisoprolol, metoprolol, atenolol, for example, any ones that end in olol, are a secondary drug which can also be used as an antiarrhythmic. These medications specifically work by decreasing the heart rate and decreasing the rate of contractions, which can subsequently slow down your heart rate, slow down your beats per minute, and of course, in that sense, is working to manage atrial fibrillation. Finally, there's also digoxin. Digoxin basically has effect on your parasympathetic nervous system, which is also known as the part of your nervous system which helps you relax. It simulates that part of the nervous system, then slows down the electrical conduction in a certain part of your heart, which of course then decreases your heart rate. And then amiodarone is also used with structural heart disease. Proarrhythmic effects specifically for this medication are low. Again, this is an antiarrhythmic medication used to treat and prevent a number of types of cardiac dysarrhythmias, which includes atrial fibrillation. Often not the first choice, but one medication that your cardiologist may consider.
So it's kind of interesting. So one of the things you think about getting rid of the rhythm disturbance, the atrial fibrillation will have an impact on stroke. The problem is the medications that we have aren't perfect. So there's a class of medications that you measure that I call the simple ones, diltiazem, verapamil, beta blockers, digoxin. They slow the heart rate in atrial fibrillation. They're not very good at preventing atrial fibrillation, but they just take the edge off the heartbeat. Stronger medications called antiarrhythmics will actually prevent atrial fibrillation. The gold standard is amiodarone. Other drugs are flecainide, propafenol, Rismol, sotalol, other drugs, but they have more potential for side effects. And they don't really, these drugs really don't prevent stroke. They prevent the symptoms of stroke. So if you're very symptomatic with your rapid heartbeat, we'll explore that. And finally, there's ablation that we can consider as well. So, but the gold standard for preventing stroke is blood thinners. You mentioned warfarin. And the other drugs that we have, the NOACs that we'll talk about in a few minutes, prevent stroke by between 65 to 70%. That's important. In the scheme of things, aspirin may prevent 10 to 15% of strokes, where the blood thinners, warfarin, dabigatran, digoxin, Xarelto, Pradaxa, they lower the risk of stroke by 60 to 70% if you have atrial fibrillation, either continuous or intermittently. So you can see that this is a complicated process, because preventing stroke is not just lowering one thing, it's protecting the vessels in multiple ways and protecting the brain. Next, go ahead there, Stu. What else do you want to tell us about this?
Yeah, absolutely. It's a perfect segue into our next conversation, which is anticoagulants. So as Dr. Curnew was mentioning, these are medications which can be used if you have atrial fibrillation to significantly decrease your risk of stroke, because these clotting medications sort of relax the formation of clots. And of course, we know that clots are the thing that leads to or oftentimes leads to ischemic stroke specifically. So there are several different options. The first one, as Dr. Curnew mentioned, is Warfarin. And with any medications, they come with their pros and cons. One significant benefit of Warfarin is that it's relatively, well, it's substantially cheap per day compared to other medications. In this case, it's usually only about 10 cents per day for Warfarin. So that's a significant benefit for many individuals, of course. But one con is that patients prescribed to Warfarin are required to undergo routine blood tests just to make sure that they are receiving the appropriate dose. So there's many different things that you can do to undergo these testings. There's at-home options. There's patient self-testing, things of that nature. So while it is cheaper, it does require a little bit more self-monitoring just to make sure that you're receiving the appropriate dose of medications and blood thinners. The other ones that you see on the right-hand side, these are the direct oral anticoagulants, as Dr. Curnew was mentioning, Eliquis, Xarelto, just to name a few. The benefits for these is you don't have to undergo significant monitoring, but if you on the flip side, of course, it is a little bit more expensive. If you get it by trade name brand, it's usually about $3 per day. The generic brand is usually at about approximately about 1.25 per day. And so really it's just having a conversation with your doctor about what would be the best medication for you, all things considered, which of course includes price as well, to reduce your risk of having stroke if you're an individual who does have atrial fibrillation. Dr. Curnew, is there anything else you wanted to add here?
I think these are remarkably game-changing drugs. You know, we're talking about, these are big benefits. This is the difference. If you have atrial fibrillation and you have more than one chat point, if you're over the age of 65, you had a stroke, you had a TIA, you have high blood pressure, diabetes, hypertension, and you have atrial fibrillation, you deserve to be on blood thinners unless you have a very good bleeding reason not to be on that. So Warfarin's been around for a long time, and I still think it's a great drug, is that you need to go for blood monitoring, and if you're doing well, that's terrific. The newer drugs, the Digoxin, which is called Pradaxa, Rivaroxaban, Xarelto, Apixaban, Eliquis, or Doxaban. In Canada, we call it Lyzinia, are being around. The good news is you don't have to go for blood tests, and they're safer for bleeding inside the head. They probably have more gastrointestinal bleeds, and the pricing is substantially more. So it's a huge difference in price, and you have to decide what's best for you, and that's with the help of your physicians and your healthcare providers. Never be afraid to discuss price. It's important, because providing things that you can't afford is a bad choice. And being cost effective is always a good thing in deciding what's right for you. The government, the Ontario government, and all governments in Canada pay for these blood thinners with certain restrictions. For instance, in Ontario, they want you to use warfarin first, and if you can't use warfarin because of you have an unstable monitoring of RNRs, or you have a higher risk for intracranial bleeds, you can go to this first-line therapy. And right now, we're using a lot of these new drugs as first-line therapy because they are a little bit better than warfarin, and they have some decreased intracranial bleeding inside the head, which is important. But they do have increased gastrointestinal bleeds for the vast majority of them as well. So that's an individual decision with your healthcare provider. So and this is something that's been a game changer. The sad part is that many people who take blood thinners don't take them properly, and stop them. So if you're not a reliable person taking blood thinners, then I prefer warfarin because I can measure that blood test called the INR to see if you're in the right range. If you take these newer agents on your right, is that you can tell me you're taking the medication, but if you're not taking them properly, you put yourself at substantial risk of having a stroke. So always have a good, honest discussion. It's amazing how many people just tend to feel I don't need it or adjust their dose on their own. This is not something you can adjust on your own. You need to work with your family doctor, your heart doctor, or your pharmacist about this right now. This is important information. Atrial fibrillation deserves to be anticoagulated for the vast majority of people. Sometimes you can't because the risk of bleeding is too high, and sometimes we have to adjust the doses. So there's so many ways of adjusting here. I don't know how to manage my electrical panel at home. I do know how to manage these things here. So if you need some help here, I can help you, and many other doctors can help you about this circumstance as well. So wonderful. These are game-changing drugs.
And I believe I'm going to be passing it briefly over to Aditi, who's then going to be introducing the topic of surgical options, specifically angioplasty, and then I'm going to be briefly discussing cardiac ablation, as Dr. Curnew was discussing.
Yeah, so in terms of surgical management, there is the option for carotid angioplasty or stenting. So we were talking about atherosclerosis, the buildup of plaque in various arteries. Now, the most common site of this is the coronary arteries of the heart, but it can also happen in other arteries in your body, like the carotid artery. So angioplasty is a procedure to open clogged arteries and restore blood flow. It can treat or prevent strokes, and it usually goes hand in hand with stenting, which is when a small metal coil is placed in the clogged artery to help prop the artery open. So on the side here, we can see what an angioplasty looks like. And then this is an image of what the stenting looks like when they put the metal coil in place to kind of maintain the openness of the artery. So possible complications for this technique include clots, bleeding. Even though it can be used to treat or prevent a stroke, it can also cause a stroke or a TIA. There can also be the chance that the artery gets further narrowed. And usually this is the choice when a carotid endarterectomy is not possible, and that's just a procedure where they quite literally go in and take the plaque out of the artery. Again, this is a method that can be used to treat or prevent strokes, but we are dealing with the carotid artery, which is what supplies blood to your brain. It is quite a massive artery, so there are the potentials for complications as a result with this surgical option. Dr. Curnew, did you want to add anything?
Yeah, so this is, it's kind of interesting, is that you have to have a certain amount of blockage, over 50 to 75%. The more the severe blockage there is, the more likely you can open it, either with surgery or with stenting. We tend to believe that surgery is the best option if you're healthy enough. If you're not healthy enough for surgery, then we can consider that option. It's interesting, if the artery is 100% blocked, you don't have to do anything about surgery or angioplasty because there's no blood clot to go up into your neck. That part of the artery is closed off. We also know that if you're having, these are for chronic strokes. Those are people who've had a TIA or a stroke, and basically, if you had a warning stroke, you have a partial blockage. Time is urgency because the risk of stroke is per day. So again, if you think you're having a stroke, you need to get to the hospital, because what can happen now is that we now have blood clot dissolving agents that can actually open the vessel. We can sometimes directly stent the vessel acutely, and that's basically a changing matter. But if you wait too long, it's too late. There's too much brain damage that's taken place. So you're thinking of all these options, and we'll talk about the end is, wouldn't it be better to prevent this from ever happening in the first place? And so think about that too as well. It's amazing that I think of physicians as working in through domains. One is that taking care of patients in crisis, and we're in crisis mode most of the time, and and so physicians and teams are very good about that, and people don't mind waiting, or we try to wait less. But prevention, we're not so good as. And then the third phase, of course, is helping you end your life palliative care and making your last parts of your life more comfortable. So remarkable technology. And it's remarkable how much of this can be prevented if you just do all the right things, from blood pressure, cholesterol, not smoking, no alcohol, normal weight, regular exercise, good quality relationships. They're so important. Please think about how to prevent this and then having to rush 911 call to the emergency room. Go ahead, tell us more.
Yeah, so as Aditi was talking about surgical interventions to manage blockages, I just wanted to briefly discuss surgical management for individuals with atrial fibrillation, and one of the main ways of doing this is something called cardiac ablation. I'd like to explain a little bit about what that is and when this is considered and when maybe this is not so much considered. So first of all, cardiac ablation basically involves the manipulation of your heart. It involves inserting catheters into parts of your heart to actually scar certain parts of your atria and manage some of the dysarrhythmias that are taking place in your heart, basically to get the electrical system in your heart back on track so that it's conducting synchronously the atria and the ventricles so that blood isn't pooling in your heart. Now, all things considered, it's a really interesting procedure where they insert these catheters up different blood vessels, which eventually lead to your heart, and the surgeon will then use various hot and cold impulses to sort of manipulate the electrical signals in your heart to sort of get it back on track. Now, many people will often decide to get an ablation because they hope it's going to make them feel better afterwards. Of course, with any surgical intervention, there's many risks. The risks may not always be worth it. They may not always outweigh some of the benefits, especially if an individual maybe has only a few symptoms, or for people who are less likely to be helped by ablation itself. Of course, you would never go into a surgical operation if there was no suspected benefit. Now, it's also important to recognize that cardiac ablation is never truly considered prior to effective management with medications and appropriate lifestyle interventions. And so it's usually only considered when there hasn't been any success with antiarrhythmic, anticoagulant medications, medications to manage hypertension and cholesterol, or for very serious or responsive arrhythmias. Now, again, as I mentioned, this is a bit more of an invasive procedure. Some people will see improvements, of course, but there is a chance that abnormal rhythms will recur following the intervention itself. And if this happens, the procedure may be repeated. And specifically, however, while this may be used to manage atrial fibrillation based on the research that I've looked into, and Dr. Curnew can provide his commentary as well, it's not something that necessarily has been used to reduce the possible risk of stroke, more just as a way to manage atrial fibrillation or the dysarrhythmias that your heart may be experiencing. You may need to take blood thinners or other medications as advised by your cardiologist to subsequently prevent the risk of having a stroke, regardless of if you undergo this operation or not. Dr. Curnew, is there anything you wanted to add to this part?
No, I think you summarized it quite well, is that ablation is more for symptomatic control of atrial fibrillation. It's a procedure that often has to be repeated. If you're over the age of 75, your heart's enlarged, you're very much overweight, it's not going to really work. And especially, so it's just something that's available. Unfortunately, the waiting time in Ontario is 1 to 2 years at this point in time once you're on the list for that. So it's not something that's done acutely in Ontario very regularly. And I think there's so many better ways of preventing atrial fibrillation from happening. So controlling blood pressure, have better sleep, losing weight, no alcohol. These are the things that are much more important than having someone burning holes or in your heart and things that nature. So certainly it's available, but it's not something I'd be rushing off to have done unless I really had bad symptoms that I can't control with some of the medications we talked about before. But the procedure is getting better. We're learning more about this. The procedure today is much better than the procedure that was 10 years ago, and we'll see what the future holds for constant developments.
Okay, great. So as I continue to play musical chairs with my colleague, I'm going to pass it back to Aditi, who's going to provide a wrap-up of surgery, and then I'm going to introduce the conversation of alcohol and how it affects your heart.
Yeah, so we've talked a little bit about medical therapy management and then surgery management, but sometimes there's the question of, is one actually better than the other? So I'm going to briefly talk about two trials that looked at a more conservative approach with medications versus a more invasive approach with surgery and see what they found. So starting off with the Orbita trial in 2017. So this was a trial that was done in patients with stable angina. So they found that in patients with stable angina, so PCI, did not result in greater improvements in exercise times or anginal frequency compared to a sham procedure. So in this case, the invasive procedure, which should have led to better outcomes, did not really cause anything that was significantly different from the sham procedure, which didn't do what the invasive procedure did. And then for the Ischemia trial, which was conducted in 2019, invasive therapy in patients with stable ischemic heart disease and moderate to severe ischemia did not reduce major adverse cardiovascular events compared to medical therapy. So what these two trials highlight is that surgical and invasive therapy could be a great option if you're young enough, healthy enough, but it does not necessarily appear to produce superior results compared to a more conservative approach involving medications and lifestyle changes.
That's really important. It's one of the things people say, fix me. And the surgeon will always say, I got you just in time. So the Orbita, these are people with blocked arteries to the heart. And it shows that is that if you think you're getting an angioplasty, you do better. And the Ischemia trial showed that medicines are just as good as having a bypass or an angioplasty in the vast majority of cases here. So, and yet people are clamming for procedures. I'm clamming for prevention at this stage. And you illustrate two trials that show in well-designed research that prevention is just as good, if not better, than having to have a procedure such as an angioplasty to the heart. And if you think you got an angioplasty, you'll do better compared to a fake angioplasty. Just imagine we did that. Instead of actually doing a real angioplasty, we gave you a fake angioplasty. You'll feel better if you didn't know that, but we don't do that, so not to worry.
Yeah, and so as Dr. Curnew's teased quite a bit throughout today's conversation, of course, alcohol actually does have a significant impact on your heart health, and I'd like to discuss a little bit of research on how reducing your alcohol consumption may actually have a positive impact on your heart. So with many of the research that's currently been conducted, we've come to understand alcohol is a type 1 carcinogen, which significantly increases your chance of developing cancer due to consumption, and it also has a significant impact on the dysrhythmias that you may often experience. Oftentimes, individuals may say that they consume alcohol and then they experience palpitations shortly thereafter. And so researchers have been really interested in this area of investigation. And so there was a recent study which was conducted in 2020. This was a randomized control trial. And what the researchers were really interested in is how does abstinence, or at least a significant reduction in alcohol consumption, have an impact on managing atrial fibrillation. And so what the researchers did across various different centers, and I believe this was Australia, was that there was 140 individuals that they recruited. These were individuals who were typically consuming about 10 or greater standard drinks per week, individuals who have been diagnosed with paroxysmal or persistent atrial fibrillation. And what they did was they randomized these individuals so that 70 of them went into the abstinence group, and then the other 70 went into the control group. Now, it's important to recognize that in the abstinence group, there was a significant reduction in the amount of consumption of alcohol they were taking per week, to the point where they reduced their alcohol consumption by about 87.5%, whereas the control group actually reduced their consumption far less. They were at about a 19.5. So in the abstinence group, while they didn't completely go cold turkey, they did significantly reduce the amount of alcohol they were drinking each week compared to the control group. And what they found was that by 6 months, the recurrence of atrial fibrillation for greater than 30 seconds decreased by 20% in the group that significantly reduced their alcohol consumption. They found that 53% of patients in the abstinence group experienced atrial fibrillation throughout that time, whereas 73% of individuals in the control group within that 6-month follow-up experienced atrial fibrillation. And what they also found was that the length that they experienced the atrial fibrillation, so the amount of time that they were actually in atrial fibrillation, was significantly larger in the control group as compared to the group which significantly reduced their alcohol consumption. And on the other slide, the next slide, we do have some pictorial representations of what the researchers found. So you can see right here on the left-hand side that what the researchers were interested in was the probability of having no recurrence of atrial fibrillation. And what they found was that over the course of 180 days, the abstinence group, or the group that reduced their alcohol consumption, had significantly higher probability of having no atrial fibrillation during that time as compared to the control group. So the main finding was that the likelihood of recurrence was significantly greater in the group that was continuing to consume a significant amount of alcohol. If you also look at the bottom left-hand side here, you'll see the direct comparison of the control group and the abstinence group. And on the y-axis, you see this was the amount of atrial fibrillation burden. So the amount of times that they were in atrial fibrillation, as well as the length that these individuals were in atrial fibrillation. And what you could see that the percentage of time participants were in AFib was greater in the group that was consuming alcohol, which was, of course, the control group. You can see that the bars are significantly greater. And you can also see that about 33 to 34% of individuals who consumed alcohol had atrial fibrillation 5% of the time, to which you can see right about here. Now, you can also see that about 47% of participants who did not consume alcohol, so the abstinence group, had atrial fibrillation 0% of the time. So you can see right here that for about nearly half of the individuals who significantly reduced their alcohol consumption, they didn't experience any atrial fibrillation throughout the course of the investigation. And so if you go to the next slide, we kind of wrap it up here with discussing what the main takeaway is here. And that's that alcohol is most commonly reported trigger of atrial fibrillation. Of course, there's other studies which connect AFib to other cardiac manifestations. But based on the research that's been conducted, and there's more studies as well, but we just focused on one, if you have atrial fibrillation, significantly reducing the amount of alcohol consumption in your diet on a weekly basis is really imperative to managing your heart health. And of course, managing your atrial fibrillation can significantly reduce the risk of having peripheral vascular disease, a stroke, heart attack, or other adverse cardiovascular events. Dr. Curnew, is there anything you wanted to add to that point?
So it's kind of interesting. This was done in Australia. This is another game-changing trial. So they tried to recruit individuals who they thought drank large amounts of alcohol. They defined large amount of alcohol greater than 10 drinks a week. Now, for many people, let's say that's not very much alcohol, but that's their definition of significant large amount of alcohol, greater than 10 drinks a week. And these people were asked to either continue on with their alcohol consumption or to stop drinking. Now, most people didn't stop drinking in the group that were told to do that, but they reduced their alcohol consumption substantially, and that decreased the amount of atrial fibrillation by roughly a third. That's huge. And so if you have atrial fibrillation, palpitations, irregular heartbeats, alcohol can play a role. And there is no safe limit of alcohol when it comes to atrial fibrillation. Yeah, we all do bad things and things of that nature as well. But when it comes to atrial fibrillation, alcohol is harmful. It's also a blood thinner. It makes you bleed more. And so this is actually, if you're troubled by atrial fibrillation, I personally would give up drinking or just drink on special occasions and realize that you'll have some increased risk of atrial fibrillation. Weight reduction, control blood pressure, good quality sleep are also important for controlling the amount of atrial fibrillation. So probably the next big barrier for most people is after alcohol is weight reduction. Then comes blood pressure. Then comes better sleep. And then we keep going further and further in this equation. So yeah, very, 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 very important information, very well done study, randomized, high quality information. Thanks a lot, Stuart.
And so with that, I think, Dee Dee, did you want me to take this slide, or did you want to take the part on diet?
I think you can take this slide. I'll take the ones after it.
Sure. So as Dr. Curnew mentioned, of course, in addition to medications, surgery, and managing your alcohol consumption, the other things that you put in your body, specifically the foods, as well as other drinks as well, can also have a significant impact on your risk of having an adverse cardiovascular event. And so very, very briefly, I just wanted to discuss some foods which are beneficial, some foods which you'd aim to cut out, and Aditi's then going to go more specifically into some specific diets that you might be able to consider or you might be interested in. So first, looking at some of the foods that, of course, are beneficial, which Aditi is going to be elaborating on a little bit further with the diets, are fruits and vegetables, making sure, of course, that you're eating whole grains, lean meats, and reducing the amount of red meat consumption on a weekly basis, consuming more low-fat dairy products, getting your antioxidants through nuts, seeds, legumes, and as I mentioned, of course, fruits and vegetables as well, which are a great source oftentimes of potassium and magnesium, are really good because potassium and magnesium naturally reduce your blood pressure, which of course then reduces your risk of having a stroke. And so these are some of the foods which you'd want to integrate into your diet. And the Canadian Food Guide also, which we've discussed in previous webinars, does a great job elaborating on what your plate should look like in terms of an effective breakdown, where about half of your plate should be vegetables, about a quarter should be grains, and the other quarter should be about proteins. Now, specifically in terms of the things you want to cut out, we understand that drinks are oftentimes empty calories, whether it's orange juices, beers, Gatorades, energy drinks, things of that nature. These are things that are very rich in sugars, and other foods as well are very rich in salts, saturated fats, and trans fats. So anything that's packaged, processed, is maybe coming in a bag, these are some of the things that we often maybe will gravitate towards at the end of the day when we're feeling a little bit peckish, but these are the types of things that can add up to having a negative impact on your health. As Dr. Curnew's mentioned, it's the burden over a lifetime, and so while maybe one bag of chips isn't so bad every once in a while, continually gravitating towards foods that are rich in salt, sugars, and saturated fats is not the way to go when it comes to cardiovascular protection. And of course, actually energy drinks and excessive caffeine as well. These are things which, rich in sugars, can have an adverse impact on palpitations, can contribute to atrial fibrillation to some extent if you're having excessive amounts of sugars and caffeines. And so these are some things you want to be mindful of in your diet. And finally, of course, eliminating the alcohol intake, as I've discussed. It's one of the best ways that you can try to manage atrial fibrillation and subsequently decrease your risk of having an adverse event such as a stroke. As Dr. Curnew so articulately emphasized, alcohol is not just type 1 carcinogen, but it's also a blood thinner. It is also something that significantly contributes to atrial fibrillation. So if you are troubled by atrial fibrillation, managing your alcohol consumption, trying to cut it out as much as you can, as Dr. Curnew said, would be in the best interest of yourself. Next slide, please. And I think I'll take this one as well. This is just the atrial fibrillation diet, which specifically focuses on reducing your salt intake to less than 2,300 milligrams per day. So how exactly do you do this? Well, first and foremost, you want to focus on having those lean meats, cutting out the red meats in your diet, avoiding, as I mentioned, things that are processed, boxed, canned, frozen meals. These are the types of things that can unfortunately sort of sneak up on you, and not recognizing that even in such small amounts, they can be really packed with some of the things that you don't necessarily want to be putting in your body, such as significant saturated fats, high levels of sugar, for example. These are things that you want to be mindful of. Limiting caffeine, potentially, or at least limiting excessive amounts of caffeine intake. Of course, eliminating the alcohol. And finally, trying to eat as many fruits and vegetables that are rich in magnesium and potassium. All these friends that you see on the right-hand side are things that are rich in magnesium and potassium, oftentimes things that are green, fruits and vegetables. These are the way to go to get those types of minerals. And these, as I mentioned, can have a natural impact on managing your blood pressure, reducing your blood pressure. And we know that managing your blood pressure is so crucial to minimizing your risk of having a stroke or having another adverse event, such as a heart attack. So if we head over to the next slide, I think Aditi is now going to be...
Actually, kind of interesting. Go back one slide there. So it's interesting is that the only thing is that caffeine or coffee is that, coffee, there was actually a recent study that came out this week that coffee, black coffee actually lowers your cholesterol. So it's interesting is that at one time coffee was a bad food, is now a good food. So having 2-3 cups of coffee a day for many people is actually could have health benefits. Where in the past we used to say having a drink or two a day was healthy. It's the other way around now. Coffee is a good food, alcohol is a bad food, and science changes. And as we learn, we adapt this. So everything else I agree totally with. Just coffee right now. If you find that you're getting more palpitation, in fact, actually coffee actually makes you keep you up at night. So for many people who have trouble with sleeping, is that maybe you shouldn't be drinking your coffee at nighttime. So there's actually studies show the day that you drink coffee, you actually have you sleep a half an hour less at nighttime, but you actually have more steps. So you exercise more by drinking coffee. Very, very interesting how you can balance all that. I just had to run to the bathroom after my soup different fluid intakes and stuff like that. So it's amazing how nutrition and how you can adapt to that. So it's wonderful that that we can actually personalize things a lot better right now. So fantastic. Thanks for sharing that. Let's look at the food guides.
Yeah, so we're going to brief.
I'm actually making some chia seeds with some oats, and I'm going to put a few little nuts in there, a little bit of cinnamon, a little bit of blueberry. So I'm actually going to try to lower my blood pressure tonight while during this webinar.
Sounds like a good idea. We're going to briefly talk about two types of diets for the diet section. So starting off with the Mediterranean diet, this tends to be one of the best sort of dietary plans out there because it really emphasizes kind of moderation, not making too many drastic changes. Essentially, when it comes to the foods that you should eat, lots of fruits, vegetables, legumes. It encourages olive oil as a source of fat and whole grains. In moderation, it's recommended that you have poultry, eggs, cheese, yogurt, and then rarely consume red meat. So we can see in this diet plan, you're not necessarily cutting something out. However, you're making most of what you consume come from sources of grains, fruits, vegetables, and legumes. And if we take a look on the right on the little Mediterranean diet food pyramid, we can see that meats and sweets tend to be at the top, but daily physical activity, grains, fruits, and vegetables are at the bottom, which means you should be getting daily servings of those. In terms of foods to avoid, the Mediterranean diet recommends you avoid added sugars, processed meats and foods, and refined grains and oils. So anything that's really heavily processed, it recommends that you either avoid them altogether or just reduce your consumption of them. So what exactly does research say about the Mediterranean diets? The biggest study is a Spanish trial called PREDIMED. So there were less cardiovascular events in the groups on the Mediterranean diet compared to the control diet. And we can see that in the graph on the side. So the groups that were relying on nuts and extra virgin olive oil for their sources of fat compared to the control diet had a decreased incident composite endpoint for cardiovascular events. And then follow-up studies to the PREDIMED study found a reduced risk of combined myocardial infarction, stroke, and cardiovascular disease. So it was 28 to 31% lower with Mediterranean diet compared to control. LDL cholesterol, blood pressure, CRP, weight reduction, these were all also seen in the Mediterranean diet. So overall, it does have a lot of different benefits for your overall health. And since the webinar tonight is about stroke, it also reduces the risk of stroke. So the other diet we're briefly going to talk about is the whole food plant-based diet. So this is a bit more extreme than the Mediterranean diet in that it encourages you to go all the way to plants. So in terms of foods that you eat, it's things like fruits, vegetables, whole grains, legumes, nuts, and seeds. You want to limit or completely avoid animal products, refined foods, added sugars, white flours, and processed oil. The only drawback with the whole food plant-based diet is you do need to be careful about some of your vitamin intake because some of it would come from animal sources. So if you're planning to go this route, you do need vitamin B12 supplementation. And in terms of what the research says about this, so a 2021 study found that it can reduce the risk of stroke by up to 10%. And there are varying degrees of a plant-based diet. So we can see in the image on the right, when we're looking at the hazard ratio for total stroke, we can see the risk is lower on a healthy plant-based food diet. It becomes a little bit higher in a less healthy one, and then it's even higher on an animal-based diet. So just because you're on a plant-based diet doesn't necessarily mean you're eating healthy on the plant-based diet. So being really mindful of the components that are there in your diet, making sure you're getting adequate servings of whole grains, legumes, fruits, and vegetables is really important. And finally, there was a 2014 study that showed a 21% risk reduction in stroke for those who eat more fruits and vegetables than the general average population. So essentially, going towards more plant-based eating, it doesn't have to be completely plant-based, but the more plants that you eat, the general overall lower your risk is for various events, including stroke. And I'm gonna pass it off to Stuart for exercise.
Yeah, sure. So one of the final pillars of lifestyle interventions is, of course, getting a modest amount of physical activity as well. And so many people living with atrial fibrillation or other risk factors may often be worried about exercise, but according to the Heart Stroke Foundation, it says that maintaining regular physical activity can have significant benefits of course, integrating your family doctor or your specialist into conversations about the amount of exercise that you should be undergoing based on the individual specificities of your health is important. But with precaution, physical activity can improve your cardiovascular health in many different ways. So whether it's just getting a modest amount of activity through walking throughout the day, taking the stairs instead of the elevator, going on bike rides if you're able to, engaging in any sports that you enjoy, engaging in resistant exercises rather than those aerobic ones listed above, such as free weights. There's just many ways in which you can get your exercise, and of course, finding what works best for you is crucial. That's been a difference for many individuals, and when it comes to finding a consistent exercise routine is the enjoyment factor, and whether that is finding a sport which you enjoy or making it social by going on walks with your friends consistently on a weekly basis. Of course, everybody's different, but recognizing the value that exercise has on your heart is so crucial, and finding little ways to integrate this into your busy lifestyle can have a very significant impact on promoting the short-term and long-term cardiovascular health. Next slide, please. So, as I was just alluding to, it's important to listen to yourself. Living with risk factors, it may be common to worry about your heart rate. If you're someone who's living with atrial fibrillation, you may be specifically worried about elevating your heart rate for fear that it may lead to an adverse event. So taking the appropriate precautions is important. And so some of the ways of doing so is, of course, beginning and finishing exercises gradually, not starting too quickly or finishing too abruptly, making sure that you're focused on your breathing and listening to your body. When you feel like you're fatigued or when you feel like you're not gathering enough air when you're exercising, then maybe slowing it down a little bit to ensure that you are getting enough amount of oxygen in your lungs as you're exercising is important. Starting off with light exercises and then increasing intensity over time is really important as well, and that draws upon the idea of those SMART goals, which Dr. Curnew often alludes to, making sure that your goals are specific, measurable, but also attainable, realistic, and focused within a certain window of time. So starting off an exercise routine that you've never done before, making sure that first and foremost you're not planning to run a marathon before you start walking first is really important. So starting your exercises slowly and then increasing intensity over time is important. And of course, if you ever do have any questions about your concerns about exercise or the amount of physical activity that you should be getting, as I alluded to, sharing these concerns with Dr. Curnew is really important, and together we can create a plan. Dr. Curnew and many of the other individuals in the clinic can help create a plan that works best for yourself. Next slide, please. And just very briefly, there's many other things which we couldn't get to today, just in the interest of time. Of course, there's so many ways that your health is impacted, and that can include sleep. It can include the amount of stress that you're experiencing. The fortunate thing is we've discussed many of these topics in the past on our YouTube channel. So our YouTube channel, Dr. Greg Curnew, or just Greg Curnew, which you can find on YouTube, has a collection of over 200 videos. Some are short, about 10 to 15 minutes. Some are a bit longer, like tonight's, which can be up to 2 hours. But many different conversations. We've done various ones recently on sleep, both a short one and a long one, which focuses on the benefits of effective sleep management and managing your stress levels, your blood pressure, your heart health, your brain health, your brain function and cognitive function. And then that's something I certainly recommend checking out. I know it's had a significant impact on the amount of sleep that Dr. Curnew is now trying to integrate into his daily life. And so with that said, I'd like to pass along to Dr. Curnew to ask him how your sleep schedule is going recently and how much sleep you maybe got over the past few days.
Well, this has actually been a bad couple of weeks because the Olympics is on, and I'm really enjoying. I'm an early riser, so I get to watch the Olympics at morning and nighttime. And the clinic has been extra busy the last little while. So, but I'm working on my sleep, and so. But I just want to say is that there's so many factors here to think about. But yes, sleep is one of those pillars that I need to do better on, and I think for many of us is that I'm hearing too many times I don't know my blood pressure. I hope after this that you think about having your own blood pressure machine. And tonight I lowered my blood pressure, I think, by having some vegetable-based soup. And one of the things that Aditi taught me recently is that kale is a good food. It has lots of calcium as well as potassium in it. That's quite good. I just having chia seeds, frozen blueberries, whole oats, a little bit of Greek yogurt, and and a couple of nuts I threw in there as well. The Predimet study was a neat trial that's showing that nuts in moderation can be a healthy food as well. So there's so many things you need to do the backbone of therapy. What else do you want to tell us again tonight?
Yeah. Yeah, absolutely. So the other one, of course, as well as stress management, we have a focus group very specifically focused on mindfulness. And that's always something that you may join if you're ever interested. I'll share the email on the next slide. If you'd always like to send us an email, we're happy to get you in that group. But stress management is really important, and so we create a number of different videos, both short and long. And actually, next week's webinar is going to be related to stress management and mindfulness. So if that is something that you're concerned about, you're more than welcome to check out some of those videos and join us next week, where we're going to be focusing on mindfulness and specifically happiness as well. So that's another one that, of course, not only has an impact on your mental health, but your physical health as well, including your cardiovascular health. And finally, I just wanted to briefly mention something known as Visipa. Visipa is a pure EPA, which is essentially a refined version of fish oils. Right now, we know that Visipa right now is an area of investigation and studies which is shown to have a positive impact on managing your cholesterol levels. And while this is not purely something that you need to be considering so much right now, especially given that it is an expensive medication, it just goes to show you that there's so much research right now going into various medications which can be used to manage your cholesterol, to your atrial fibrillation, to your hypertension, and things of that sort. And so as new information comes about, Dr. Curnew and his team of volunteers is going to be constantly updating you with new information to ensure that you have all the tools that you need to take health into your own hands and facilitate open conversations with Dr. Curnew based on the things that we discuss in our webinars. And so very briefly, I'd like to just transition over to the next slide, where we just wanted to thank everyone for joining us. And if you did have any questions or would like to join any of the focus groups that we have going on, we do have a Google form in the description of this video, which you're welcome to check out with the list of all the activities that we have. And if you would like to join anything, you're always more than welcome to send us an email at drcurnew232@gmail.com, and we'll get you into the program of your choice. I'll pass it over to Dr. Curnew. Is there anything you wanted to add today, Dr. Curnew, before we call it an evening?
Well, first, I want to thank the team for reminding us that stroke is an important disease. It's an important disease that causes disability, and there's different causes. So you mentioned is that if you're thinking you're having a stroke, you have weakness on one side of the body, you can't formulate words properly, you think you may having a stroke, call 911. And in Hamilton, you want to go to the Hamilton General Hospital, which is the stroke center. The ambulances will divert you to that if they can, because time is brain, and brain is what we want to keep you going as long as possible. We now have the ability, we quickly image the brain. We do a CAT scan, make sure there's no blood inside the brain. And then we have blood clot dissolving agents called TPA. There's direct angioplasty to the brain at this point in time, and we want to control blood pressure and control risk factors appropriately. But 80% of stroke is reversible. So controlling your risk factors, so knowing your blood pressure, knowing your cholesterol. If you smoke, please try to stop. And these factors are important. It's interesting that alcohol is rich in calories, it gains weight, but it also increases the risk of atrial fibrillation. So that's new findings. You mentioned Visipa, fish oil, pure EPA actually decreases overall stroke, but also increases atrial fibrillation. So, where that fits into your repertoire, that'd be up to your physicians to work with. If you had a fresh stroke, you'll probably be on 2 blood thinners for a period of months or 2. If you have blocked arteries in your legs, you'll probably be on aspirin and low dose Xarelto. Getting blood pressure to 110 to 130 systolic is our goal for most people. Getting LDL cholesterol as low as we possibly can is another goal as well. And so I think you showed us so much information out there. Don't forget your diet and lifestyle changes, and keep working at it. And thank you for sharing. And are there any questions out there? I know one time during the interview, someone said they didn't like stroke. I think, they use the S word. I think stroke is a bad disease, but preventing stroke is something we can do a much better job at. I see we have Gary has a question there. Is that right, Gary? Go ahead.
Yes, I'm on. I have AFib. I have usually around 2 episodes a month, which last for generally 2 days. Have there been any studies done on what triggers the heart to go into AFib and what triggers the heart to go back into sinus rhythm?
So it's a good question. So Gary, the heart's electrical as well as a pump. Now, we know the number one trigger that for most people turns out that you can do something about is alcohol. So if you know, so no alcohol means no alcohol. For every drink, you increase the chance of having atrial fibrillation. So what you can do is that when the heart's in atrial fibrillation, it's under stress. So what causes stress? How much you weigh, what stress factors are playing a role in your life, what your blood pressure is. These are things that you can control. Do you have good quality sleep? Do you have sleep apnea? Those are some of the things that we think about. Is the heart structurally normal? Is your heart thick or thin? Does it have scarring in it? Does it have valvular heart disease? So those are a bunch of factors that you and I have to go through individually through our checklist about this. For many times, it's just we're getting older and the heart tends to fibrillate more. I think as we get older, everything just doesn't work as well. Just remember, we have these young 20-year-olds that are telling us what to do. And they're at their peak performance. As they get older, they're going to become just like us. I want to use the word I shouldn't use, but basically by healthy aging, by doing the things we talk about, by the weight, by the blood pressure, by eating sensibly, we can decrease the amount of atrial fibrillation. We can't totally eliminate it. We do have medications to slow down the heartbeat that works for many people. We do have antiarrhythmic agents. My favorite would be, in your case, a drug called amiodarone. If you're using any over-the-counter fish oil tablets, you should stop them. They increase atrial fibrillation. And there's so many factors. So we'll have to review that at an individual basis. I have to make sure we have to do an ultrasound test to see how the structure of the heart, are the valves and the heart working well. Very interesting that many people think they have atrial fibrillation. They have normal heartbeat. So we'll have to do a Holter monitor to just check into that. So you're asking a great question. So I hope I have answered some of it. And we're still learning as well. At one time, people think coffee is a trigger for atrial fibrillation. It turns out not to be a trigger at this stage. So as we learn through learning about COVID, other infectious diseases, information changes, we adapt to change. And so you're adapting. So my wish for everybody is to get to a body mass index of 20 to 25. I think that has a great impact on the amount of atrial fibrillation for people. Make sure the blood pressure is controlled most of the time. If you have atrial fibrillation that happens a couple of times a month, you can decrease a third of atrial fibrillation by no alcohol whatsoever. So some of the things that you can control, some of the things you can't. And we're still learning about other factors. I hope that was helpful. Any other thoughts? Gary, did I answer your question?
Yes, you did. Like when I go into it, I just relax to try and get out of it. I don't know anything else to do to get out of it,
We can give things like beta blockers to slow the heartbeat to help you get a little bit quicker. But the good news is that if you're taking your blood thinners, the risk of serious complications is very, very low. So that's good that you don't have to rush to the emergency room with your atrial fibrillation because you know how to deal with it. And that's wonderful.
Thank you.
Thank you. Thank you. Now, the first time you have atrial fibrillation, it's a very scary process for many people. And some people never actually ever feel their atrial fibrillation. Today, for instance, I saw a gentleman in the office whose heartbeat was going 120 beats per minute. I thought he was an atrial fibrillation. Turns out he was just a normal sinus rhythm. We did the ECG to find out. So I have to find out. So I have to make sure I have the right diagnosis. So when I think of a fast heartbeat, I think of atrial fibrillation. Those were just normal heartbeats. So we have to. So we have them on a pathway to figure this out right now. So much to learn. Well, listen, I'm going to just thank the team. It's wonderful. This is another one that we'll review and share with others. I want to bid everybody a nice weekend and be a little bit healthier. And we'll see you next week. Take care, everybody.
Take care, everyone. Have a nice family day.